Hello, and welcome to this month's Simon Says Expert Series. I'm Mark Green. I'm a professor of radiology and imaging sciences and director of radiopharmaceutical sciences at IU. And I guess I'll start with what is a radiopharmaceutical? It's a drug that contains a radioactive isotope. I perform research at the interface of chemistry and medicine, trying to exploit radiation emitted by that radioisotope for making medical images or delivering radiation therapy. As part of Men's Health Awareness Month, our experts today will focus on prostate cancer, which is the second most common cancer in men behind skin cancer. It's a pleasure to introduce you to Dr. Clinton Bahler. He completed his urologic surgery residency at IU School of Medicine and chose additional specialty fellowship training in laparoscopic and robotic surgery. He enjoys bringing medical advances to patients and is currently a principal investigator for a clinical trial using advanced PSMA-based imaging in prostate cancer. Our second expert is Dr. Mark Tann, a graduate of the Ben Gurion University of the Negev Medical School in Israel, who specializes in abdominal radiology and nuclear medicine. He plays a pivotal role in research and clinical work at IU and IU Health, and he's a leader in training current residents and fellows. Dr. Tann has played a critical role in IU's efforts to bring advanced imaging with radionuclide agents into the clinical care of local cancer patients. Thank you both for sharing your expertise with us today. And before I turn things over to Dr. Bahler, I'll note that at the end of their presentations, we will come back to questions that were previously submitted, as well as any new questions that you pose in the chat window. So, Dr. Bahler.
Hey, thanks, Dr. Green. Yeah, thanks for the opportunity to share. We feel very fortunate that we spend our days in the clinic or the operating room trying to maximize quality of life while at the same time treating cancer. And are my slides viewable as expected here? Let me shift to presenter mode.
Looks good, I think.
Okay. Yeah, so we wanted to talk about prostate cancer. Of course, that touches a lot of us since it's such a common cancer. Disclosures, I do consulting work for a number of companies which are listed here. Telix actually does have PSMA targeted imaging and treatment products. And Sonoblate is a company that has focal therapy in prostate cancer. So both related to this presentation. Okay, and Dr. Green had mentioned, prostate cancer is very common. And in terms of cancer deaths, it's number 2. Now, while about 1 in 8 men will be diagnosed with prostate cancer, it's probably more on the order of 1 in 20 would have clinically significant cancer. And that's one of the first things to note. Currently, there's a category of prostate cancer that's called low risk, or some of you may have heard of Gleason 6 or a grade 1. And, those are, and there's a huge debate over whether or not to categorize that as a cancer or not, or just a pre-malignant lesion. And so that has led to a lot of confusion with prostate cancer. So if you're reading online or in the newspaper and you hear, most men have prostate cancer but don't die from it, that's in large part due to that low risk category. But that raises the question, and how important is it to have good staging, good imaging, and good predictive tools? And that's what we want to talk about today. So you can safely know if you're in a category that does not need treated. Prostate cancer is more likely to occur in older men and also Black men. We were chatting before it started. Obviously neither of those are modifiable factors. There has been a lot of research in nutrition, diet and nutrition, lifestyle. And there's good data to show that a heart healthy diet is what helps prevent prostate cancer or slow prostate cancer down. So heart healthy would be low carb, and heart healthy would be your healthy protein. So your nuts and fish and lean meat. And the big things that get us, I think, in the Midwest at least, are all of the all the breads, all the white things, white rice, white bread, white noodles, and those are heavy carbs or pure sugar in the body. So, okay, prostate cancer is rare in young men, and the average age is about 66. Where is the prostate? What does the prostate do? Why do we have that? It's essentially a reproductive organ. So the prostate provides support to sperm, and so it helps to build the prostate and seminal vesicles, basically build the semen or the ejaculate. It sits right below the bladder so that the urine goes through the prostate itself. And one interesting thing most folks don't realize, prostate cancer does not enlarge the prostate. So prostate cancer is a little bit unusual. A lot of other cancers form mass lesions, but prostate cancer, it more forms an infiltrating lesion that replaces normal prostate tissue. So prostate cancer is not typically going to show any side effects. And in the age of PSA screening, now before PSA, before that screening test, when prostate cancer was diagnosed by symptoms, if it's progressed enough, it can cause a difficulty urinating, but that's very rare today. Okay, one of our guiding principles is this do no harm or beneficence. In other words, we want to treat patients like family. We get sick too, and so Dr. Green, Dr. Tann, and I both are very passionate. The patient should not be worse off for seeing us. And when you're considering surgery or radiation, serious treatments, that becomes difficult, and we're all wanting better tools, better imaging to help know who needs treatment, who's going to benefit from that, and who can be observed. Okay, contemporary diagnosis. PSA, one of the questions we get is a lot about PSA. And the biggest thing of PSA is it's elevated for multiple reasons. So if you have a large prostate, that's not your fault. You can blame your mom or your dad for that, just genetic. But that's going to raise your PSA. Or if you have a grumpy prostate, so that would be prostatitis. Sometimes there's no symptoms, we call that subclinical. But so your PSA can be raised for a large prostate, an irritated prostate, or prostate cancer. And it's really just with PSA screening, it's really all about figuring out if you have an elevated PSA, what's the reason for that? And once you adjust for your prostate size, once you adjust for prostate irritation, then PSA it's a remarkable prostate screening tool, meaning a very accurate, very sensitive prostate cancer screening tool. Some of these other tests are trying to help do that. So 4K score is a bit more specific than PSA. We run those in our urology clinics. There's urine tests now. SelectMDx is an example. And then fortunately, the MRI now is used as a tool to help decide if biopsies are needed as well and to guide the biopsy. So, all right, a little bit on PSA. Again, there's a lot of questions about this, but it's extremely accurate or sensitive for detecting prostate cancer. The problems come in that multiple things can make it elevated. So one of the easy things we can do is adjust what we consider a concerning PSA based off of your age. And so you can see a table here based off of data in specific populations. For instance, for white men, that PSA where we get concerned enough to do a biopsy changes depending on how old you are. Basically, that's adjusting for your prostate as your prostate grows over time. And then in terms of prostatitis or prostate irritation, never trust a single PSA value. So if your primary care checks a PSA and it's elevated, the first thing you want to do is wait 3 to 4 weeks and recheck it. And oftentimes it comes back down. And that means you just had some prostate irritation or a grumpy prostate. So you want multiple PSA numbers. In other words, it's not an individual PSA check that matters, but it's the trend over time. And when we do that, and when we consider prostate size, then PSA becomes a very, very sensitive, accurate test. This is just a slide showing the blue line. This is metastatic prostate cancer, what we're all trying to prevent. And it's showing the introduction of PSA screening back in the late 80s, early 90s, and how the incidence of metastatic prostate cancer dropped significantly. Just comparing that to breast cancer metastatic rates over time as well. Okay. Now, the biopsy itself, it's a clinic procedure, 5 to 10 minutes. And if the numbing shot is done well, really shouldn't have a lot of pain with it. One of the benefits today is with MRI and with targeted biopsy, generally means you're going to need fewer biopsies or fewer cores because we can be more exact. And so that's been a big benefit. Okay. I guess I should pause. Some of you may have had a biopsy, so we want to be empathetic with you and that experience. Sometimes they are done in the operating room, and there's different, you can do them transrectal or transperineal. So there's different ways to do that. Now, a really, really important improvement that we saw is just in how we describe the biopsy. And the grade of a cancer is saying, if we look at it under a microscope, how aggressive does it look? And the new system, the grades go from 1 to 5, and it was always confusing. The old system, the Gleason system, goes from 6 to 9 or 6 to 10, and that was confusing for everybody. So thankfully, the new system is from 1 to 5. And so just pause here. And this is a very busy slide. Sorry for that. But a lot of biopsies are benign. And, we just found out you had a big prostate or prostate irritation. This grade 1 category, it's a category that in general we say does not need treated. And so that unfortunately was a cancer or a tumor that was treated for decades. And so, we got data back from randomized trials showing that it does not benefit patients to treat that. And now we have better imaging and biopsies too. The grade 2 is an early cancer, generally cured with a single treatment. And I mentioned HIFU or focal therapy. That's a less aggressive treatment, but there are some advantages, less side effects. Robotic surgery and radiation are your two standard of care treatments. And then the higher grades, we're always still hoping for cure with a single treatment. However, just more likely that you could need multiple different treatments for cure. Okay. Robotic surgery, just one slide, the technology keeps getting better. For instance, today, following this talk, I'm going to use a single port robotic system, and that means all the arms can work through a single incision. Essentially, it means it's outpatient surgery now for most or a lot of the robotic surgery that I do for prostates is an outpatient surgery. So the healing is quicker. Of course, the advantages of robotic surgery over open is when we use cameras, we can get really close to the prostate, and it's better in terms of sewing everything back together at the end of the case would be one of the ways it's better, in addition to healing. But almost all prostate removals in the United States are now done through the Da Vinci system because of its advantages. And now focal therapy, we do want to we do want to brag a little bit. HIFU was invented here at Indiana University about 25 years ago. And so HIFU is a focal therapy, a heat-based therapy. And some men are candidates for that, especially if your cancer is early and it's focal, it's not widespread throughout the prostate. So the quality of life and the side effects, quality of life is really good after HIFU. Okay, we're about 20 minutes after. So I'm going to finish with a case here, and then I'll hand over to Dr. Tann. Of course, I look forward to answering questions as well. This was back in 2019. It's an African-American gentleman, only 59. PSA was elevated. The biopsy, I'm showing the old system here. So 3+3 is what we now call grade 1, and 3+4 is what we now call grade 2. The question with all the treatments, the prostate's just a reproductive organ. So the side effects come not from treating the prostate or removing it, but it comes from injuring the structures around the prostate. For instance, the muscle that gives you urine control, or the nerve tissue that triggers the erection. And so one of the biggest questions is the cancer contained in the prostate, or could it be spreading out onto the skin, or through the edge or the boundary, through the capsule of the prostate? And if it's contained in the prostate, then we can save all the muscle and all that nerve tissue, and you're likely to maintain sexual function or erections, and likely to maintain complete urine control as well. This is a slide, and I know this is another busy one, so I'll slow down a little bit here. This is showing the MRI as compared to the PET scan, and then finally the prostate after it's been removed. And the point of this slide is to show that the MRI is overestimating the prostate cancer, and the PET scan is more specific to where the clinically significant prostate cancer is. And so the PET scan here enabled us to do nerve sparing. Now, I have to say I need to quickly add, the PET scan is not FDA approved for this indication, meaning the PSMA PET scan is not approved for guiding nerve sparing, but that's research that we've been doing for 4 to 5 years and have published on. And currently we're NIH funded for a trial to study the PET scan for guiding surgery for nerve sparing. And I would say huge thanks to Dr. Green and Dr. Tann. Dr. Green informed us and brought this technology to us at Indiana University, probably at least 5 years ahead of most other universities. So we've been using this from around 2016, whereas most institutions just got this imaging in the last year or two. So just to finish up, when you treat cancer, the goal is always to personalize the approach. In other words, whether you're treating the radiation with HIFU or with surgery, you want to really personalize the treatment so you maximize the quality of life, or you minimize the injury to surrounding structures and organs. And the MRI and the PET scan and other newer tools are helping with that guidance. Again, the PSMA PET is currently approved in cases where there's concern of metastasis. And so that's where the bulk of the PET scans are now being done in prostate cancer. However, as more and more research is being done, we suspect the PET scan will be used more, maybe for biopsy guidance, and potentially surgery guidance too. So in conclusion, better imaging leads to better treatment and higher quality of life. And I'll stop there and turn things over.
All right. So I think we'll turn to Dr. Tann, who can provide an overview of some of the current and what's new in imaging technologies for trying to better characterize the extent and location of disease in prostate cancer patients.
Okay, well, thank you, Mark, for the introduction, and great talk by Clint. This is a little more advanced. So I'm a radiologist, so I'm the nerdy kind of doctor that most people don't interact with. I'm the guy behind the scenes that looks at the images and tries to communicate with your doctors to explain exactly what is going on. and how best they can manage what's in the imaging to give you an optimal therapy. So like Clint here, I'm going to disclose that Telix supports some research that we do here. So there's been a seismic shift in how we take care of prostate cancer. And that's based on over 10 years of research in PSMA PET from Europe. And it's changed how we do everything. And all the modalities and ways that we used to do things that we thought were the best, they've all been replaced by PET, and we need to adjust to this seismic shift. So my colleagues talked about how many people have prostate cancer, how common it is. And I'm going to talk briefly about diagnosis, primary staging, detection of recurrent, and the therapies. So Dr. Green briefly discussed what is PSMA. It's you inject a radiopharmaceutical, which is a radioactive drug used for diagnosis or therapy. Then you go inside one of these fancy scanners called a PET-CT scanner, where they take a CT scan and then a PET image. They fuse both these modalities together, and you get a really useful combination. So this is what it's like reading a CT or MRI, a bone scan. If you can look really carefully, you can probably guess what type of animal is there. But when you put the CT and PET together, it's the difference between looking at the screen on the left versus the screen on right. And that's why we like looking at PSMA scans, because it's just easier. If something is less challenging to read, we're probably going to get it right the first time. So again, if you kind of look at a CT scan on MR, up to 1,000 images of black and white, kind of hard to look at to see what's going on. But as soon as we add the PSMA scan, we have a color picture, which people like, and then you can separate which is the color we don't like, and it's usually orange. And then it's a lot easier to find what we're looking for in this picture than it was in our original picture over here. So that's why we like it, because it's easier to do. So why is it important? Why is it important that your imaging study should be as accurate as we possibly can? So unfortunately, when people don't have a lot of knowledge, there's fear, and there's an overwhelming desire to reduce risk and assume the worst. And this leads to shotgun approaches. And if we have an accurate diagnosis, we can have therapy. So if we would take this little cartoon, we would like to move all therapies from something like that to one arrow perfectly targeted. So we haven't done a very good job with imaging for the first probably 40 years of doing it for PSMA. PSA has kind of pointed us in directions, but it sometimes causes us to overtreat or undertreat. And we don't want to make wrong assumption on disease, because we won't treat, we don't want to treat PSA levels and not the disease. And our overall goal is to have the most accurate therapy. So what is it? What is PSMA being approved for? We're going to talk briefly about pre-treatment. How advanced is the cancer? That will be the first thing we talk about. Then we'll talk about biochemical recurrence and then advanced disease. So the first step is it limited to the prostate? If we just treat the prostate, will it take care of your disease? And we've got literature showing that it's better than anything else that we've had, but here's a nice little example. So this is a patient that had right-sided prostate cancer. Again, just like Waldo, here's a gray image. No, I don't see there's any cancer. But when you merge it with the PET image, any fool, precisely myself or Clint, can work out there's something wrong here. But I'm going to focus on this small little node that we see on the left-hand side. So who would expect a right-sided prostate lesion to give a left-sided node? If you look at the CT picture of the node, there's no way that we would call it. But quite easily looking at the PET image, yes, we see it, and it's real. And that affects therapy. This would have made just thinking that you could take out the prostate gland a complete waste of time if you don't take care of that gland as well. So that's the advantage we get with PSMA scans. And I'm very excited that we've, for 5-6 years, had the opportunity to offer this service for our patients here at IU. So let's take a couple of assumptions that we've had in the past. that one assumption is all the prostate gland, when you don't know where the tumor is, let's assume it's all a tumor or all going to turn into a tumor. So let's radiate everything. Unfortunately, the consequences of doing that is you may be less effective for the one lesion and you may cause side effects elsewhere. Or if we don't know if the patient has nodal disease, let's just radiate the entire pelvis where we think there may be pelvic disease. But that's not always the case. So these pictures here show what is a standard radiation therapy. And then the pictures on the right, which I'm showing now, show that there's only one lesion in the prostate, and it's in the left upper quadrant. So that's the only place we treat. However, we also see a single node, and it's not everywhere throughout the pelvis. It's just one in the mesentery of the bowel. So therefore, we know we should treat, so we can move from a shotgun approach to a targeted approach. And hopefully we can reduce the radiation field and reduce the potential side effects while optimizing the therapy. That's what it's all about. Can we find every single node with a PET scan? Unfortunately, we can't if it's smaller than 1 millimeter or 2, but anything the size of 3 millimeters is excellent. We can do that easily. Where should you get your PET scan? So your question would be, is how old is the machine and how are they doing the scan? So in our experience, when we upgraded from one machine to a newer machine, we increased the sensitivity from like 13% to 38%, which is what you would probably be aiming for small nodes. So yes, you need the newer and better scanners. So the key question in initial staging, is it worth doing even if we have an MRI scan? And the answer is yes, because it's better at finding high-grade disease and to find nodal and metastatic disease. The MR had an advantage looking at local extension for surgical planning. However, a PET's getting pretty close, so yes, it's worth doing. What is the next indication? Biochemical recurrence. What does that mean? That means you had your radiation or your surgery, but the PSA is rising, and we want to know where the disease is. If you don't know where it is, how will you be able to treat it specifically and accurately? So this was kind of pre-PSMA imaging. Let's just radiate the entire pelvis and prostate bed, regardless of where we see tumor, because at that time we didn't know how to find it. And this is what treatment looks like after we have PSMA. So we want to optimize the individual's targeted therapy and reduce collateral damage, preserve quality of life. And we've got some older studies from Europe. As I said, Europe has been leading us for the past 10 years, saying by doing a PSMA scan, you change the management by quite a large percentage than if you looked at the standard image. And we have other trials done here that if you base your radiation field on what the PSMA sees, you have a better outcome than ignoring it, which is probably not surprising. So how good is the scan? If it's done correctly, we can find small foci of disease in areas which were up till now hidden from any imaging and any kind of non-invasive trial. So that's kind of gives us confidence. So, and there's also, when do you sit on something? Are you confident that disease isn't getting worse? So here's a case where you can see the patient 2 years ago had a little node and a single bone lesion. We repeat the study, nothing's changed. The patient can relax and be sure that no aggressive therapy needs to be done because we don't see the disease getting worse. Or we can see that whatever therapy is keeping disease under control. What is the third option? Advanced disease. So when disease gets worse, where is it? Is it in the bones, in the nodes? Should you have chemotherapy? Should you have other therapies? And that's the third bit. So this is the example of something that's new to America that's only been going on for about 6 months. That's treating people with radioactive PSMA, which has a different isotope that can actually treat disease. So this is a picture of a patient that has very diffuse advanced disease all throughout the bones. We give them radioactive PSMA with a different agent that causes damage to the tumor. And we can see it does a pretty good selective job of reducing that tumor. And that's PSMA therapies, which is relatively new for advanced disease. We can also quantify better than we ever did before, is the therapy working? Much better than we could ever do with CTs or with MRs. So we have a better idea of what's really going on, and we can make decisions much earlier. So investigational use, I'm going to see how long we have to chat. We got a few more minutes. Surgical planning. This is investigational. We use this for research, and I'm very lucky to have Doctors Green and Bahler who are pushing us to do the job. How can I provide an individualized surgical plan to have the best efficiency and the least amount of collateral damage? So here's pictures of patients prior to surgery, and we can see it's not everywhere within the prostate. There's that focal disease. So we want you to focus the surgery on this area, but all the rest, you don't have to be so severe. You don't have to cut into the local structures in your desire for curative intent. And here's another case over here. Same idea. We know where it is. When you know where it is, you can reduce collateral damage. Okay, what else do we have? Biopsy guidance, primary diagnosis. So how to be sure where the most advanced disease is. And again, we've got, do you trust the PSA? Do an MR? What do you do when the pathology is negative, but the imaging study is pretty positive? So we've got quite a few researchers saying, if you have a lesion like this, no matter what pathology is showing, you still have cancer. So it's probably a sampling error. And so that is investigational at this time, but we see it has great promise for the future. So what are the key questions in prostate cancer? Initial detection. Is it worth doing it if you have an MR? Well, probably yes, because the MR doesn't find all of the cancers. And sometimes it overestimates the burden of disease because it picks up lower grade disease. However, PSMA usually ignores the benign and just the most aggressive high grade. Is it useful in active surveillance? Probably yes, as it gives us a better picture of what's going on and more accurate. So we can see in summary, the PET is a pretty good tool that helps us improve prostate cancer management at all stages. Again, make sure that you're on the most recent PET scanner. Make sure that the protocol you're going to a place that does early images, gives intravenous contrast. Otherwise, you won't be able to accurately pick up small disease and differentiate between urine and lesions. So we believe that there'll be an awful lot of scans coming down, and there'll be an awful lot of therapies, and we need to be prepared for that. So now we're going to move to the question and answer time. Mark Green, over to you.
Right. So thank you, Dr. Bahler and Dr. Tann, for those nice overview presentations. So we do have several questions, good questions that were actually submitted ahead of time. And so I'll just go through some of those now and let the two of you field them. First one's probably going to be mostly for Clint and really deal with what should be the guidelines for prostate cancer screening.
So prostate cancer is a very slow growing, slow moving cancer. And that in that interest of doing no harm, if you really need to benefit from treatment, you need to have a life expectancy of probably at least 10 years because PSA detects cancer so early. At the time of PSA detects a cancer, you're generally 10 years ahead of that, spreading and causing symptoms. So that's the first kind of rule of thumb. The other, as men age, we say, hey, you've graduated out, just like you graduated and eventually, hopefully, don't need colonoscopies. The same should happen with PSA. Whether you stop screening it at 70 or 75 or 80, probably depends on your health. When to start screening? If you have high risk factors like a family history, or or African American ethnicity, you might have your first PSA at 40. And we don't recommend necessarily starting a yearly PSA screening at 40, but having a baseline at 40 may be the right thing to do, and then a second at 45. But for the majority of men who are not at increased risk, the recommendation by most associations would be to start having an annual PSA at 50 years of age. And typically that's primary care doing that. PSA can be done with a rectal exam, but in many offices, the PSA has replaced the rectal exam. In other words, it'd be quite rare to have a prostate cancer that did not have an elevated PSA. It's possible, but very rare. And so between the ages of 50 and 70 is the most important range. And we'd recommend an annual PSA. And then again, if the PSA is high, we want to see a trend. So it should be repeated. Give it a month to come down and repeat that before you get concerned. And also realize you could just have a large prostate as well.
Okay, right. And we had somebody indicate that I'm having an MRI done to check on my prostate. What can I expect from this MRI?
Unfortunately, the MRI is a fairly tight tube. Now, one benefit of your prostate being low, below the belt, so to speak, is that you should be able to go into the scanner feet first. Certainly you can request that. But it is a fairly long exam too. It's a 45 to 60 minute exam. Mark Tann, do you want to update any of that description? I think you're mute. Yeah.
Yep, you're bang on.
It's a bit loud too. Sorry, go ahead.
Yes, so the overall idea is to find, is there cancer, yes or no, and what is the extent of the cancer that is seen as how it would affect your treatment options. That would be the goal of the MR scan.
And I think maybe Clint could also talk to what determines when you use that MR to actually guide your biopsy.
Yeah, the MR gives us your prostate size, so it's accurate sizing. There's cases where, let's say, if your PSA is 5, that could be high or that could be totally normal. In other words, if you have a large prostate, a PSA 5 may be completely normal. So the first thing we look at is your PSA actually high now that we know your prostate size? If the MRI shows a lesion that's really suspicious, that's the most helpful, because then at the time of biopsy, we make sure that we biopsy that area. So if the MRI, and unfortunately, there's a spectrum. You can have an MRI, a spot on the MRI, the radiologist says it's only slightly suspicious, and so there's a spectrum of grading. Shouldn't use the word grade, but suspicion levels from the MRI.
Okay. And someone asked, is it true that COVID-19 infection can temporarily raise your blood PSA level?
So Dr. Green, thankfully, did literature search on this. And, if you have any active infection, COVID-19 included, probably, or there's a good chance, there's some likelihood that it'll raise your PSA. And it comes back to, if your prostate's irritated at all, then your PSA is probably going to raise. So you want to wait about a month after any active infection to have your PSA checked. If your PSA is checked during an infection and it's elevated, most likely it's the infection. So it should give you peace of mind. Just repeat it in a month.
And someone wanted to know, do you look at pathology in real time during the course of the surgery?
Yeah, there's been a lot of work. In fact, my introduction to Dr. Green back in 2000, probably 15, 16, was this question: during the surgery, can we look for positive margins? And there's some really exciting trials coming out. In other words, with that PSMA as a target, there's now fluorescent dyes that can be used during the surgery. So essentially, as you remove the prostate, we can turn on a fluorescent camera and look for cancer left behind. So look for that positive margin. Currently, to check a margin, and we do this if we have a concern, what we do is we'll have to, once the prostate's removed, if there's an area we're concerned, we'll have to shave that area off and send that to the pathologist. And that can be done as a frozen section while you're asleep, so that we know if we need to remove more. But it's a cumbersome process, and obviously it depends on us sampling the right area. So a more targeted approach we think will be better.
Okay. Right. While we don't have a radiation oncologist here, I think both Dr. Tann and Bahler are referring patients routinely for radiation therapy, so they can still probably answer this. And that really was, what recent changes have been made in prostate cancer radiotherapy to reduce side effects associated with the treatment?
Dr. Tann, you want me to go first, or you want?
Well, the goal is, if we can more accurately know where the tumor is, and probably more importantly, where it isn't, one can spread the dose of radiation to optimize where it is and reduce it to where it isn't. So you would have the maximum effect and the minimum collateral. There's also other techniques where people have managed to move bowel loops out of the direction of where they're going to be radiating, sometimes with position, sometimes with fluid. So as the machines have got better with the introduction of the concept called SBRT and proton therapies, you can get a lot more. I'm not a radiation oncologist, but people can get a lot more accurate and specific. And the concept of blind therapies should be something left in the past. Clint, what do you say?
Yeah, exactly. The Spacer is a product that can be injected to push the rectum away from your prostate, just like Dr. Tann was mentioning. And so I think that's a good thing to try and decrease the rectal toxicity or irritation to rectum. And then they're also compressing. This probably doesn't change side effects, but classically radiation was given over 6 or 7 weeks. So it was a lot of treatments, short treatments, but a daily treatment. And they're trying to compress that. So now it can be done over a week or 3 weeks, so that it's not quite so burdensome from a time standpoint. We're collaborating with radiation doctors here, especially Dr. Omar Ishak, looking at how we can adjust the dose based off of the PSMA PET, just like Dr. Tann was mentioning, trying to set up trials. The thought being we can reduce side effects if the PET is accurately showing where we need to focus treatment.
Okay. And so another question was, are there any symptoms that the patient should be looking out for that are a tip-off that they may have prostate cancer?
This is a huge, I think it's a source of confusion, because I feel like when you go online and symptoms or signs or symptoms of prostate cancer, what you get is a list from the 60s and 70s. Does that make sense? Back in the 60s and 70s, there was no PSA. There's no way to screen for prostate cancer. And so prostate cancer is a silent cancer, meaning you're not going to have any symptoms for 10 or 15 years from when it starts. And so it'll say, weak stream, trouble urinating, but that's really, we almost never see that today. Because if cancer is making it hard to urinate, that means your PSA is like 200. And, now if you're screening with your PSA, you're having that PSA. Once it gets over 3 or 4 or 5, you're having a biopsy. So today we really don't, it's sad, and we still see it occasionally. And that's a tough situation, because at that point, there's no cure. But there's really no side effects of detecting prostate cancer early. The side effects from the cancer are late, and the other major late side effect is when it spreads to bone. Of course, you can have bony pain from that spread to bone, but again, that's a late side effect.
Someone asked, has the starting age for prostate cancer screening changed recently? And that obviously that may require a nuanced answer, because the right answer is going to be different if your father or brother has already had a prostate cancer diagnosis.
Yeah, that's exactly right. I don't want to address the controversy over prostate cancer screening, and I consider it very unfortunate. But back in 2008 to 2012, there was a U.S. preventative task force looking at one major study that had been done in the U.S., and they said screening for prostate cancer is not beneficial. But it later came out and they were not initially honest about the data in the study. But it later came out that both groups in the study had extensive PSA screening. So the study really didn't compare whether PSA helped, as both groups had a lot of PSA screening. So, but PSA screening, during that time, there was a drop off in PSA screening. But I do have to admit that there was a lot of over treatment. There was PSA screening that led to biopsies, that led to a lot of over treatment of low risk cancer for decades. And so a lot of men were harmed with over treatment, and this probably that tension led to some of what happened 10, 15 years ago. But to be more specific, we believe early detection means you can catch a cancer smaller, you can catch it in time for cure, but also hopefully catch it in time for the least aggressive treatment, which could even be a focal therapy, focal radiation, or heat treatment, or if it's radiate, or if it's surgery, a nerve sparing surgery. More specific to your question is, if you have a brother or father, so that'd be a first degree relative with significant prostate cancer, then we would recommend your first PSA potentially being at 45 or 40. But the most important thing is to not overreact and realize multiple things can elevate your PSA.
And then we had a question of, is the digital rectal exam necessary, or is the blood PSA test good enough?
Yeah, I think most doctors now would say that it's appropriate to only use the PSA. There are some cancers that don't cause the PSA to be elevated, but those are extremely rare. And so, PSA is going to catch the vast majority of prostate cancers.
Okay. And a question that just got posted was, what is available for treatment after anti-androgen therapy? And this causes more of a Dr. Adra's world, but Clint can probably address that as well.
Dr. Tann's doing a lot of that. Yeah, Dr. Tann, you want to chime in?
So for people who have failed, so what was this, failing castrate resistant, there's chemotherapies. And I think this October, we'll be offering radioactive PSMA that has a therapeutic intent rather than diagnostic extent before chemotherapy, but usually one moves to chemotherapies if you have an aggressive disease, which is castrate resistant. And only after the chemotherapy do you prevent for something called Pluvicto, or labeled PSMA with an alpha or beta. That's the newest and fanciest. That's what we're doing a lot of here. Yes, there are therapies.
Okay. And the one last question that's posed ahead of time dealt with ongoing clinical trials in this realm. I don't know, Clint, if you want to speak to that just briefly.
Yeah, we have an active clinical trial department. We have an active collaboration with the medical oncology, as well as radiation oncology and nuclear med as well. Dr. Tann here. We have a monthly meeting. There's a number of clinical trials for prostate cancer at Indiana University. Another category is immunotherapies for prostate cancer, therapies that try and attract your immune system to the cancer. So and then Dr. Tann's talking about radionuclides or radiotherapeutics that are more targeted to the cancer. And hopefully all those will make hormone therapy, or we call it, that's castration, just much less, because that can be difficult, has a lot of difficult side effects. So our goal is that we could prevent that.
Okay.
If Nabil Adra or Jennifer King are the two medical oncologists here at Indiana University. They're phenomenal, really remarkable physicians and people. And they're the ones that we send the patients to discuss all the potential clinical trials and which ones they may qualify for.
Okay. All right. Well, thank you, Dr. Tann and Dr. Bahler, and thank you all for tuning in to join us for this month's Simon Says. You can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. Thank you.
Thanks.